Those of you who are interested in back injuries and the back in general, I'm sure everyone here has had to deal with that in their professional career. We have Dr. David Strothman who will be presenting next.
Well, thanks for having me. I gave a very similar presentation to a conference like this about, I don't know, 8 months or a year ago, and apparently somebody liked it, and so I'm back to talk to you again. This is going to be your medical piece of the day, I think. It's going to be a little bit more detail, a little bit of anatomy. I'm going to bring you guys through a little bit of understanding what we do in spine, because I'm sure what all of you have noticed throughout spine care is that everybody does something different, and everybody thinks they're right. So I do things different, and I am right, but I'm going to tell you all about why that is. And so the point of today's conversation is really getting to what is minimally invasive spine surgery, how are paradigms in spine care shifting, and then coming back, how does that apply to what you all do in workers' compensation and getting people back to work, getting back to life in general. And so first thing we got to do is we got to understand a little bit about the spine. And so all right, so here's a sagittal view or side view of your spine, and basically in the lumbar spine there are bones and there are discs, right? On MRI scans in general, you got to understand a little bit about it to understand this talk. We generally look at a T2 sequence on the MRI scan, which means that water is bright white and everything else gets a color based on how much water it contains. So if you look at this MRI scan here, there are 5 bones in your low back, and in between each bone is a shock-absorbing disc. Now you see that some of those discs appear white and some of those discs appear black, and that's very simple because the discs that are white contain water, the discs that are black don't, and that'll apply across the spectrum. The front of the spine is here, the back is here, back behind your bones and discs is going to run your spinal cord nerves. So the spinal cord typically ends about L1, turns into a bunch of nerves that look like a horse's tail, right? We call it the cauda equina, which just in Latin means horse's tail, which travels down the rest of the way through here in a fluid-filled sac. So all this white stuff back there, that's all spinal fluid, it's all water that's surrounding your nerve. Now we also look at the spine cut up in cross-section. Okay, so our axial or cross-sectional views are here. This is a cadaver section, which is show the disc space at L4-5. You have 2 joints in the back of the spine called facet joints. Underneath those facet joints lies a ligament called the ligamentum flavum, which is a yellow ligament. Gets a little bit bigger as we get older. And then right in the middle is that cauda equina or sac of fluid, dural sac, whatever we want to call it, space for the nerves. So on the MRI scan, again, disc, bone in the back, here are the joints. Now the image is flipped, right versus left, because we look at people chopped up in cross-section, bottom to top, not top to bottom. So cross-sectional images are always flipped side to side. This white circle that you see there, that's that spinal fluid sac. And then each little black dot within that sac of fluid is the area where the nerves travel. And so those nerves are arranged like our freeway system. Nerves that are going to travel the furthest, they sit in the middle. Nerves are going to exit out of the spine. They get onto an off-ramp area. They travel down an entire level in that off-ramp before they exit off the spine. So that off-ramp there and there becomes very, very important because that's the narrowest dimension to begin with. So that's where nerves get pinched. They can get pinched in the middle, but usually it's to the sides of the spinal canal. So the lumbar disc, right, so it has 2 main layers. It has an annulus, which is a really strong ligament on the outside, and then it has a nucleus, really softer. We think of it like the jelly inside of a jelly donut. It doesn't feel like jelly. It doesn't look like jelly. It is actually more like chicken gristle, if you will. And the relationship between those two becomes important with disc herniations and other pathology. Unfortunately, our disc space has a very, very poor blood supply. So anybody who smokes in the room or knows anybody who smokes, this is the problem, is that there's no blood vessels that go to the disc. The blood vessels come into the bones, then you have smaller blood vessels that come out and tiny little capillaries that come to the edge of the end plates, the edge of the bone, and then all the nutrition of the disc is actually by diffusion. So smokers, you constrict those tiny capillary blood vessels, you don't get blood supply to the disc, and the disc starts to generate faster, people have bigger problems, and they have a hard time healing fusions. So there's a natural process of aging that goes along with your spine. So first thing that happens is the disc starts to degenerate. It narrows, it starts to settle. It goes from looking white to looking black. Basically, you're losing proteoglycans, which are molecules that attract water into the disc space. And as you lose those proteoglycans, you lose your water. Now, interestingly, people that go to space, astronauts, right, when they go to space, they get taller because at nighttime when you lay down, you actually suck water in, and then as you're up walking around during the day, you lose water all day long when you're up and walking. So if you get rid of gravity, our discs get healthier. So if we all live in space, our spines won't wear out, at least till we come home. So as the disc wears out, the joints in the back, they experience additional stress. The disc space settles. That ligament, this yellow ligament that we were talking about, that gets thicker and bigger. And as that disc settles, it unfolds inward and pinches on the nerves, as well as that disc bulges backwards, as you see here. And all of these structures, as these joints get bigger, this bulges backwards, this grows inward. Everything is confining to pinch the nerves in the middle. In time, as the joints become increasingly worn out and unstable, they can start to slip and slide. And so you get this effect called spondylolisthesis, where one bone shifts forward on another. And that can be stable, where you see it on an X-ray or an MRI scan, it's not actively moving, and also be unstable, where it actually shifts back and forth, which can cause a lot of pain for people. So there are several different things that cause pain in your spine. There's a disc, there's facet joints, and then there's your nerves, right? And we all know that compressed nerves can hurt a lot. About 80% of our load goes through the front of the spine, 20% through the back of the spine. Now, traditionally, we have thought of the spine very, very simply, and that is that nerve compression causes leg pain or arm pain, and facets that are wearing out or joints that are wearing out, discs that are wearing out, they cause low back pain. And it was that simple. We just divided things across that spectrum. But I would argue that it's not that simple. And the reason is this little bugger here. So this is the sinovertebral nerve. It's a tiny little nerve that comes off of the dorsal root ganglion outside of your spinal canal, loops back in underneath the pedicle that's here, and it innervates the back of the annulus and the disc space. That is the nerve that we believe causes back pain. Well, guess what? If you pinch that nerve out here, it causes back pain. So pinched nerves can cause back pain. We see it all the time. You think about the patients you've had who have a disc herniation and have horrible back pain. They may also have leg pain, but they have horrible back pain. You go in, you take out that disc herniation, back pain goes away completely. Okay? So nerve pain can be back pain, and it's not as simple as just saying, oh, your back hurts. It's got to be that your back's getting older, things are worn out and degenerative, and that's what's causing it. It also doesn't mean that every patient with a back pain needs to have a fusion operation, which was kind of the stigma back in the 1990s, was that if you had back pain, that meant you got a fusion. It's not that simple either. Decompressive surgeries work very, very well for isolated low back pain for the right patients. So a lot of different things cause back pain, right? Muscle pulls, degenerative discs, facet degeneration, arthritis, tumors, infections. And so we're always trying to figure out all these things. But there's this really important conversation happening right now around the country. It's centered on low back pain as a treatment algorithm, right? It's expensive. Nobody wants to pay for it. It's one of the biggest causes of disability in the United States, and it's one of the biggest cost generators for all the payers, right? So everybody wants to figure out, how do you manage low back pain? Well, I would argue that we got to think about things a little bit differently. So if you take a symptom like shortness of breath, and you say, okay, we're going to treat shortness of breath, and everybody with shortness of breath is going to be treated with an antibiotic. Well, that makes sense. So you got a patient here with pneumonia, they've got some fluid in their right lower lobe, we're going to give them antibiotics. Well, that's going to work out pretty well, right? That patient's going to be pretty happy, they're going to get better. Hey, Dr. Strothman, that was awesome, thank you so much for that pill. Well, you take another patient who's now got the same symptom, right? Shortness of breath, and you treat them with an antibiotic, but now their chest x-ray is full of fluid. So they have congestive heart failure. They have fluid everywhere. You give that patient an antibiotic, it's not going to make a bit of difference, right? So they're going to end up in a whole lot of trouble and get worse and worse and worse. And so this isn't as simple as we can think of a treatment algorithm for low back pain. We have to establish a diagnosis for our patients, and we have to treat that diagnosis, not their specific symptom. So common conditions that we're going to talk a little bit about: herniated discs, degenerative disc disease, spinal stenosis, spondylolisthesis. I'm going to make everybody say spondylolisthesis a few times. So disc herniations, right? You guys have all seen this. Patients present sudden, severe, searing pain. They're miserable. Typically, it's legs more than back, but it can be both. And I've certainly seen patients with a disc herniation have only low back pain. It's usually more to one side. It usually follows the radicular pattern as in this Netter diagram that you see. And people usually have positive tension signs, which means you straighten out their leg and they go, ah, because they're making the nerve longer. You elongate the nerve, it causes more pressure on the disc herniation, pain gets worse. but not everybody follows that pattern. So there was a good study done a little while ago looking at these Netter diagrams saying, okay, an L5 radiculopathy comes down my lateral thigh, lateral calf on top of my foot. And they had patients who had a known disc herniation that should be in the right spot, and they had them diagram it out on a computer. And Netter's totally wrong. People don't follow the exact patterns that we think they do. Okay? Now, some do, but not everybody does. And so there's some variability that exists there as well. So here's an example of a disc herniation on an MRI scan. So this is the disc at 4-5. Here's your spinal canal. All of that black stuff in the back there is the disc herniation. Here on this MRI scan, here's that axial image. This is the disc herniation here. That's the sac of fluid that surrounds the nerves. There's your little gray dots. Remember, this is where that nerve should be living, off to that left side in the lateral recess out to the side, that off-ramp area. But instead, that nerve is getting pushed way down there. So that hurts. Patients with degenerative disc disease, okay? Totally different entity. Patients with degenerative disc disease present like this gentleman here. They can't sit, okay? Pain with sitting. You got to change positions all the time. You can't get comfortable. Constantly shifting positions to remain comfortable. On this MRI scan, you can see no nerve root compression at all, just one isolated disc that's wearing out. So spinal stenosis. So when we look at spinal stenosis, again, this is the normal spinal canal. This white sac of fluid, that's the space of the nerves. These little gray dots are the individual nerve roots. When we look here, again, we talked about the process of aging. As this ligament gets bigger, the facet joints get bigger, the disc bulges backwards. Everything is convening to press on the space of the nerves. Here's an example of a patient with spinal stenosis. You look there, you look at how much water is in the spinal canal, and then you look there, and there's just no water that remains. So patients with spinal stenosis, these are the patients that you see walking in the grocery store, bent over, pushing a grocery cart. Okay? They can't walk. They can sit all day. They love to sit, okay? But they can't walk to their mailbox. They can't walk anywhere they want to go. They have to sit down. This would be somebody at a dinner party who's having a conversation with somebody, and they got to sit down when they're talking to people because they can't stand through an entire conversation. The reasoning is as you stand, you narrow the spinal canal further, so they can't stand. But as you sit down, you bend forward, you flex the spine, you pull that ligament out a little bit, make a little bit more space for your nerves, so you're more comfortable sitting. So degenerative spondylolisthesis, okay? Now this is that end of that degenerative process, okay? The important thing here is that basically your spine is a set of concentric circles that stack upon each other, and the nerves run right down the middle of it, okay? Well, if those circles all line up, there's lots of room for the nerves to travel. But if this bone shifts forward on another bone, and those circles offset, well, suddenly your spinal canal gets significantly narrowed. Patients with spondylolisthesis, they present with a very typical pattern, and it's a mix between this idea or symptomatic pattern of degenerative disc disease and the patients with stenosis. They can't stand and walk. They hurt like the dickens when they stand and walk. When they sit down, they feel better for a couple minutes, but because that bone is slipped forward still when they sit, their nerves are still pinched, and so they can only sit for a few minutes, and they got to get up and walk again, and they got to sit again, they got to walk again, and they got to sit again. So they're a mixture in presentation of the two symptoms that we were just discussing. So what do we do with spine surgery? Well, I would argue that as a spine surgeon, I have arguably one of the simplest, most straightforward decision-making jobs that's out there. The technical aspect might be a little bit more complicated than some things, but the actual decision-making is pretty simple. I do like two things. I take the pressure off of things, and I fuse things together so they don't move. Now, we've added some disc replacement technologies, particularly for the cervical spine, so there's some things changing there. But for the most part, we do really two different things. So what do we do with disc herniations? We do a discectomy, right? Take out the disc. So here's an example of a disc herniation that was taken out. They can be fairly substantial. You can see how it kind of looks like gristle from a chicken bone. It's not soft jelly. It's actually pretty substantial stuff. And this is data from a National Institute of Health study called SPORT, which is really good data showing the advantage of surgery versus non-surgical treatment in patients who have had at least 6 weeks of symptoms and failed reasonable conservative treatments. Okay? And so in patients who haven't responded to surgical care by 6 weeks, the top line is surgery, the bottom line is not having surgery. Patients, both groups get better, but patients who have surgery get significantly better than patients who don't by 6 months. And then that carries out all the way now to 8 years. We used to say, and you guys have probably heard this, that if you had a discectomy or you didn't, you ended up in the same place in 2 years. Okay? That's what I learned when I was in medical school and residency. It's not true. 8 years after surgery, patients who have a discectomy are functioning better than patients who didn't if they didn't make significant progress and get better during those first 6 weeks after the time their symptoms started. We really like to get at disc herniations within 3 months of the time the symptoms start because very simply, people do better. And if we can get at them with 3 months less of symptoms, people do really, really well. There's also data to show that once you get past 6 months, the results of surgery aren't as good. That's our challenge here. The number one challenge we have with work comp patients is getting people in to have surgery so that they don't fall into that 6 month where now things aren't going to be quite as good as they would have been, right? So that we can have patients in the long run that are there and not here. So, disc degeneration. This is the single most controversial thing in spine care, okay? What do? Well, we either do a disc replacement or we do a fusion. Now, I'm not here today to talk about disc replacement technologies, okay? All I'm going to tell you is that the data to date for disc replacement versus lumbar fusion are identical. The results are the same, okay? So a lot of payers haven't adopted it because it's expensive and there's no real proven benefit to be better in the lumbar spine. Now, the cervical spine is a totally different animal, but in the lumbar spine, they're the same. So we're just going to talk about it as our data from lumbar fusions. And now this is, in my opinion, the best done study looking at lumbar fusion results for isolated disc degeneration. There's a study done in Sweden by Fritzell in 2001. 63% of patients that had lumbar fusion got better, which isn't great, right? That means 4 out of 10, almost half the patients didn't get better. This isn't saying they did great. This is just saying they got better. They checked the box that I'm better than I was before. But only a third of people who didn't have surgery got better. So you can look at that 2 different ways, right? If you're a payer, you look at that and go, oh my gosh, I don't want anybody to have an expensive surgery that only works 60% of the time, right? Or you can look at it from the patient and say, well, gosh, I've only got a 30% chance to get better without surgery. I've got a 60% chance to get better with surgery. I want to have surgery, right? So that's our disconnect. And then you also have a disconnect or a change in the way people see things as physicians, because nobody wants a clinic where 4 out of 10 people are unhappy, right? If you have a big surgery and we fuse your spine for disc degeneration and you don't get better, you're unhappy, right? That's a bad outcome. And so nobody really wants to do that. And so you get in this really hard conversation about who gets that surgery, who doesn't get that surgery, and when should we do it and when should we not. The other problem with it is you wait until everybody's failed everything. Well, you're almost pre-selecting people that are going to do poorly because they haven't gotten better with anything else. So it gets really complicated really quick. And so we try hard to avoid surgery for just isolated disc degeneration. So spinal stenosis, well, we have 2 different options now. Traditionally, yeah. Yeah. It was a prospective randomized controlled trial, which you could only do in Europe because patients in the U.S. would never go for that, where they said, hey, you failed all conservative treatments, and they had everybody go through everything, 6 months of conservative care, and then they randomized them into having an operation or continuing further conservative care. Well, they had 1 year and I believe 2-year follow-up on those patients. Yeah. It was not a long-term study. So let me see where I was. All right. So spinal stenosis. So we can do a laminectomy, which is here. Take the bone off the back of the spine, make the space for the nerves, which traditionally takes away the bone in between those 2 red lines. Okay. And we also have some minimally invasive techniques today. This is data showing from, again, sport studies. Looking at the results for a laminectomy for spinal stenosis. And I think there's 2 things to note. Number 1, surgery does much better than not having surgery in patients who have significantly pinched nerve, who have not seen significant clinical progress. Now, this is at 3 months, okay? These are 3 months of conservative care without significant benefit. These patients do better with surgery than they do without. But I think the thing to note is this is age-matched normals. They are not getting back to age-matched normals. And I don't know for sure why that is. I suspect it's because stenosis is caused by arthritis. It's caused by the joints getting bigger, okay? And so when you do a decompressive procedure for spinal stenosis, you're not taking away the arthritis. You're just making more space for the nerves. So the nerve pain component of things gets better. People can go back and they can stand and walk much, much better. but patients still have some back pain. And so when you're trying to differentiate out, does surgery help or does it not help, there's things that it helps predictably and there's things that it doesn't. And so I think that's a good illustration of that. But people still do better with surgery than they do without. So degenerative spondylolisthesis. Well, again, we have two different problems here now, right? We have pinched nerves. We have a bone that is slipping out of position and pinching the nerves further. And so we need to combine two different treatments. You need a decompression to get the pressure off your nerves, and you need a fusion operation to hold those bones steady so they don't slip anymore. And 4-year results of this are truly impressive, okay? I would argue this is one of the best surgeries that we do as spine surgeons at making patients happy. And this is a fusion surgery, right? And so look at this. So 5-6 months, patients are at age-matched normals, okay? These patients do better than our spinal stenosis patients. Surgery versus not having surgery, this is at 4 years, okay? We're going to have 8-year data soon, but it's also maintained over time, okay? So again, patients with spinal stenosis and degenerative spondylolisthesis who have failed 3 months of conservative treatment do better with surgery than they do without, even 4 years, and then once we have the 8-year data, I'm sure it's going to show even 8 years later. This is another study which is kind of a show and tell. They compared the outcomes of SF36 scores, looking at total knee and total hip patients, which we all know are great, right? As an orthopedic surgeon, we say, hey, this is the best surgery we do in the world at making people better. These people are so happy. Well, guess what? A decompression and infusion for spondylolisthesis has the same improvements in quality of life as a total hip or total knee. So we all worry about adjacent segment degeneration, right? Wow, we don't want to fuse the spine. The other level's going to experience more stress. It's going to wear out. Well, yes, it is. It's going to experience more stress. But keep in mind that when you're doing a fusion operation, number one, you are trying hard not to fuse a normal segment, right? You already have abnormal mechanics at work. And so in a patient with degenerative spondylolisthesis, where the bone is actively slipping back and forth, other levels are already experiencing additional stress. So we don't have a way to factor that in when we look at this data. And then there's other things at work. People that wear out levels in their spine are prone to wear out other levels in their spine, right? And so I like the Schizelli study from 2004, when it basically shows that when you look at patients who have a decompression and infusion, by 5 years, about 16%, and that's actually seen in the sport data as well, are going to need another surgery. And by 10 years, it's roughly a third, okay, are going to be looking at having another surgery. What we don't know is what proportion of those patients would have needed another surgery if they didn't have surgery to begin with, right? And that number is not zero. What we don't know, is it 36% or is it some number lower there? And we just don't know that today. The other thing that I'm going to show you is that this is a patient of mine, and it's just, interesting. So this patient had a fusion long ago at 4.5 and 5.1 without screws and rods. This was done back in the 1970s. They fused the spine pretty straight. This is all fusion mass here. This is the first mobile level here at L3-4. You can see the black is that ligament in the back, so it's still moving. That level's fine, but then the level above it wore out. If this was truly just about mechanics, this level here should have been the one that wore out, right? It's the level directly adjacent. So why did one additional level above that wear out? I don't have an answer for you. I'm just telling you that it's not as simple as you put screws and rods in, you make that segment stiff, now the one above it's going to wear out and you're going to need another surgery in 10 years. It's just not quite that straightforward. So minimally invasive spine surgery. What is it? Well, I don't know. Everybody's got a different definition, okay? I think the goal is simple. We're trying to do the same things that we did with open surgery, but with less collateral damage. Smaller skin incisions, smaller damage to the muscle and surrounding soft tissues, okay? Well, why? Well, there are major problems with open spine surgery, right? There's paraspinal muscle damage, you have blood loss, you have longer recovery, other levels of wearing out, and this idea of failed back syndrome, which I think is like one of the funniest diagnoses in the world. This means that surgery didn't work, right? It's not actually a diagnosis by itself, although there is a code for it. So this is my patient, okay? So I'm not making fun of anybody else. This is an open decompression infusion. And you see this white glistening thing right up there? That's the facet joint. That's the capsule or the lining of the facet joint at the level that above where we're fusing. In order to put screws and rods in the spine in an open technique, we have to take all the muscle off the top of that joint. Well, what do you think that does to the joint in the long run, right? It's got to do something. And so is that partially responsible for why people develop other problems down the road? And if we can spare that joint and not strip the muscle off of it, Is that by itself in the long run going to give people a better functional outcome? We don't know yet, but I suspect that it will. And so the real problem that comes down with open surgery is that we disrupt these two muscle groups, the multifidus and longissimus muscles. And basically, when you do an open fusion or even open decompression, you make a skin incision down the middle, you strip and tear all this muscle out to here, down to here, and then out to the tips of this transverse process here when we're doing a fusion. And so you're taking all that muscle and you're pulling it way out to the side. When we come back and we do revision surgeries, that muscle is turned into one big ball of scar, okay? And it's dead, it's not alive, it's been totally denervated, and it has no really function anymore other than being a huge scar ball. The advantage of minimally invasive surgeries is that muscle, when we come back again, it's still alive. It's still contractile. You touch it with a bovie and it's jumping all over the place. It's totally alive. There's a complete shift in paradigm in what we do. There's some data behind this that people have done quantifying studies looking at MRI scans, looking at the amount of muscle after percutaneous fusions versus open fusions, showing that the percutaneous fusions have more muscle mass after surgery. But I like this. This is just a simple picture, right? I could show this to my fifth grader and she would tell me which one would she rather have. Would you rather have an open surgery or would you rather have the minimally invasive surgery, right? Assuming that they're going to accomplish the same things. So we have data showing less soft tissue damage, less blood loss, shorter hospital stay, lower infection rates. And as I'm going to show you, there's even some data today now showing lower complication rates, both medical complications, heart problems, lung problems, things like that after surgery, as well as lower technical complications with minimally invasive fusion. And the reason for the lower systemic complications is there's less inflammation, less inflammatory markers, less stress to the system, so people are recovering better with fewer post-surgical complications. Proposed advantages, well, we think people have a faster recovery. Yeah, that stands to reason. We think in time there'll be less adjacent segment disease. It's not proven yet. We don't have that long-term data, but we think that that is going to be a potential advantage. We know that the paraspinous muscles work, okay, but do they function the same? Again, studies are lacking, but I can tell you anecdotally, again, when we go back in to take out screws or things like that, and people that have had a minimally invasive surgery, that muscle is still alive. We believe there'll be improved overall patient outcomes, and then, like I said, fewer systemic complications. Well, what are the disadvantages? Well, at first, there's an increased operative time, there's an increased use of fluoroscopy, there's a steep learning curve, and then we don't have that long-term outcome yet, outcome data yet. So what are the fusion rates? What are the long-term outcomes? And how do technical complications fare, right? Particularly as people are learning how to do these types of things. Anytime you learn something, you're going to get into some more problems at first. So I really, really like this slide. And the reason is it's from a competitor in Florida. I'm not going to mention their name, but it's on their website. And they advertise that you're going to come down, you're going to hang out in Florida or Arizona, and you're going to get this minimally invasive procedure. They're going to put a Band-Aid on your back. You're going to go to the beach in your bikini. That is not what this is about, right? That is absolutely not what this is about at all. And so the length of the skin incision is not the problem. That's not it at all. Skin heals side to side, right? It doesn't heal top to bottom. You can make as long a skin incision as you want. It's not going to affect somebody's recovery at all, okay? Now, that being said, we all like to show off how small a skin incision we can make because that's what patients see. But that's not what matters, okay? What matters is that you do the same exact operation that you would do as if you were doing it open, just with less damage. So if you have a nerve that's pinched, you got to get the pressure off that nerve. That's it. You have to get the pressure off that nerve. If you're doing a fusion operation because somebody has instability or you've chosen to do a fusion operation for degenerative disc disease or scoliosis, you have to achieve a solid fusion. You have to do the same thing. If you don't do the same thing, you've done your patient a disservice. And they may think you're great at first, particularly after they spend $20,000 with their own cash and they got to go to Florida and everything else. But in the long run, it's not going to pan out. So we use a surgical corridor that was described by Wilkie back in the 1960s. Okay? This is not new. What is new is some of the technology and retractors that we have today that they didn't have back then. So we use a corridor between the multifidus and the longissimus muscles, where we come down to the outside part of the spine rather than coming down the middle. We now have tubular retractors that allow us to do this with good visualization, being able to see what we can do. This is not arthroscopic surgery. Okay? This is not looking down a scope. This is surgery using your direct visualization. Some people use a microscope. I prefer loops because I like to be able to move my head around wherever I want. But you can do it by different techniques that way, but it's not arthroscopic. The tubes expand. And I'll argue with anybody that all we need to see to do what we need to do is right here. We don't need to see anything else. So the indications is the surgery can be done for basically almost any condition in the lumbar spine. Okay? Now, what are the contraindications? Well, they become very few and far between. Okay? Now, the data on trying to treat long segment degenerative scoliosis with minimally invasive surgeries, I think still needs to get worked out because I don't know that we're going to achieve the same long-term goals. Okay? But the rest of it is really coming together. Now, the only real contraindication would be this particular patient who's had previous surgery here, previous fusion here. They've worn out the level above with stenosis. They've got a spondylolisthesis down below. So this is a patient who needs extension of their fusion up and down. You can't do that through a tube. And they need to have all their old stuff taken out, right? So there's some patients you just simply cannot do a minimally invasive surgery on. So we're going to talk for a minute about degenerative spondylolisthesis. And I mean this to be a little bit of an illustrative point of how we used to think about something and how that paradigm is shifting as we start looking at minimally invasive procedures. And so the gold standard for degenerative spondylolisthesis with stenosis is a fusion and decompression, as we already discussed. And that comes from these three guys, Harry Herkowitz, Jeffrey Fishkin, and Mike Kornblum. And so the first study by Harry Herkowitz showed that if you did a decompression and fusion for degenerative spondylolisthesis and stenosis, 96% of people had good or excellent results, compared to only 44% of people that had a decompression alone. Well, that got people's attention. So we started doing a decompression and fusion. Now, this is back in the day where not everybody used pedicle screws. There used to be a huge controversy about whether or not you put in pedicle screws or you didn't put in pedicle screws. There were lawsuits and everything else. So this is back before everybody got a pedicle screw. So what happened is his fellow, Jeff Fishkin, followed that up several years later and looked at patients who had instrumentation versus patients who didn't have instrumentation. Because some of you that are older in the room probably remember a day where people were arguing about, do screws matter, right? And initially people said, no, it didn't matter. And this is the study that they would quote because clinical results at 2 to 3 years were the same. But look at the fusion rates. 83% of patients with instrumentation fused versus 45% of patients without instrumentation. So next fellow comes along to Harry Herkowitz's program, and they do another study where they follow these patients up now at 7 years, okay, almost 8 years. And patients who had a solid fusion, good and excellent results still at 86% of patients. Patients who didn't have a fusion, who had osteoarthrosis, only 56% good and excellent results, okay? So patients who had a solid fusion did better than patients who didn't have a solid fusion. So that's where we got to where we are today. Patients with degenerative spondylolisthesis and stenosis, they get a decompression and a fusion. But there's other things to consider that aren't a part of that initial data. Number one, stability. So bones can be stable or unstable. If they're actively moving on x-rays, we get flexion extension x-rays, by more than about 4 millimeters, we consider that to be an unstable segment. The other thing we look at is facet joints. Facet joints, the joints in the back of the spine, have a specific orientation. They're a check rein, right? They keep things from sliding forward. So when they're oriented at a 45-degree angle, they keep the bone from slipping forward. But as that angle becomes more front to back, then there's nothing to hold the bone from slipping back and forth, and it starts to slip as the disc wears out. Also, the amount of fluid that sits within the joints. As the amount of fluid, the white fluid inside the joint increases, it's a sign of instability. Essentially, think of it like the joint is floating, right? And so it's lost the friction to keep it from slipping and sliding back and forth. And so we've taken that and we've come up with these risk factors for instability that we don't really need to go into, but these are the things that we're thinking about. And so is there a role to actually do an isolated decompression for a patient with spondylolisthesis, right? I just told you the gold standard was a decompression and fusion. Well, I'm going to argue now that there are some patients who don't need a fusion surgery and will do just as well with an isolated decompression. And so with minimally invasive techniques, we're using that tubular retractor, we're making smaller skin incisions, and we're not causing as much collateral damage. Well, this was modeled by a group from Chicago, and what they found is that if you do a minimally invasive decompression compared to an open decompression, you have 4 times less instability with the minimally invasive approach. So With minimally invasive surgeries, we may be able to alter that paradigm a little bit in the appropriately selected patients. Now, the appropriately selected patients is the part that we argue about on podiums at our medical conference, right? Who are those people that can get away with having a minimally invasive surgery versus having a fusion operation, right? Now, I would argue that an traditional open laminectomy in a patient with spondylolisthesis is still an absolute no-no, okay? Should never be done. That is not going to turn out well for somebody in the long run. However, with minimally invasive techniques, there may be the ability to get the pressure off the nerves and get people back to function with a much smaller operation than what they otherwise would have had. So, a couple slides looking at nuts and bolts and just talking about how we do some of these things. It's going to be a little bit over the top of what you need to know, but it's kind of cool show and tell type stuff. So minimally invasive discectomies, we don't need to go through where the skin incision is, but basically we drop a tube down in the back of the spine like you see here, and that tube lines up with the disc space. And then our corridor to do that surgery is right here between the red lines. We're coming right down, we'll take away this bone, take away this ligament, and that gets us down to the nerve that's going to be pinched right there. And that little bulging disc right there, that's what we're going to take out. And so we can actually do 2 different levels through one skin incision, and that's because the spine is lordotic, it has a curvature, so the exit point through the skin is in the same spot. And so you can do more work underneath through still the same small skin incision up on top. So open decompressions, okay, open laminectomy, traditionally is taking away everything between the 2 red lines. You burr down the bone, take down this bone here, take out that yellow ligament, take the pressure off those nerves, basically taking the roof off of a tunnel. Okay, that's a laminectomy. A minimally invasive decompression is different. We take a tubular retractor, dock it on the back of the spine, and we make a small hole only on this side. We take down the bone here to get access to that ligament. Then we tilt the tube, come underneath the bone, take out the ligament to the other side on top of the nerves. So we haven't disrupted any of the muscle here on the other side. How do we do that? Well, make a skin incision a little bit more lateral. We dock the tube just a little bit different. It's going to be perpendicular to the lamina rather than to the disc space. And then again, as I just showed you, we're going to take out the pressure off one side and then the other side. And then we come back to that same side again and finish that off. Now this red arrow, this is where people get into trouble. I don't know if you guys need to know this, but this is where you get dural tears because the bone here is right next to the dural sac right there. So easy to put a hole in that sac of fluid. So it takes some experience to figure out how to manage that and not have to cause those injuries. This is an example of a minimally invasive decompression. This is what we're looking at. So here's the tube. Here we're looking at the dura. That's the whitish blue stuff and a little bit of blood around it. We're taking down the bone here and taking down bone over the top. So essentially we're coming across the top of the nerves to the other side where the nerves will be pinched right over here. In fact, you can see the opposite side better than you can see the same side because you're looking directly at it. And so it's a really, really nice approach to decompress the nerves on the other side. In fact, when patients who come in and they have leg pain only on one side or most of their pain is one side, I'll make their skin incision on the opposite side of their pain because I can see the other side better than I can see the same side. So a little bit of change in paradigm. Paralateral discs, this is where minimally invasive surgeries were first started using tubular retractors. Great approach for that. It gets all the muscle out of the way. And essentially what you're doing here is that this model is a little bit off. I apologize. The nerve actually sits up here and the disc is there. But the point is that the disc herniates outside of the spine and it presses on this little swollen area of the nerve called the dorsal root ganglion, and that causes horrible searing pain. Okay? I mean, people that get pressure on their DRG are miserable. And so we can come from the outside without cutting any bone and just move the nerve to the side and pluck out that disc using a tube. Synovial cysts, great application for minimally invasive surgeries. So here is a cyst right here. It's that white structure. The dural sac, which you no longer see has no water in it, is right there. And so that cyst is compressing on everything. These, again, we like to approach from the opposite side. Because if you look at that trajectory, right, straight down right at the cyst, and these little buggers, they tend to grow into the lining of the sac of fluid, and they can be relatively adherent. And so it gives you a really nice trajectory to try to free up that cyst from the underlying dural sac so it's no longer adherent to it. It makes it a little bit easier than taking out rather than coming right down on top of it and having it in your way. So minimally invasive transforaminal lumbar interbody fusion. When we do fusion operations, we modify our techniques a little bit with minimally invasive surgeries. There are some tables that are very helpful in doing this. We start our skin incision a little bit more to the outside rather than straight down the middle as traditional surgeries are done. Now that's usually about 4 centimeters. I'm very lucky that my 2 fingers are exactly 4 centimeters. So I just lay down 2 fingers in the middle of the spine and mark the outside of my fingers, and we're in exactly the right spot. So first thing we do is we localize using a K-wire. So you can see the wire coming down to get to the right trajectory. This is all about trajectory. It's all about being at the right angles. And then we pass these dilators down, so we're pushing the muscle out of the way rather than cutting and tearing it the way that we would with a traditional open surgery. And then we fix the retractor again in the right position. So right and wrong, you have to be in the right place. Now this is what we're going to see. When we first get down, we're going to be right on top of the facet joint, and this is the area that we really need to see. I've marked in black the areas that are important. This is our working area. We expose the lamina, take off a little bit of muscle sitting on top of the lamina so we can see the bone edge as well. I used to put in screw holes first. I don't do that anymore. It just slows us down, but we used to do it that way. And then we take off the joint completely. So this is how we do a key lift. You take down the entire descending articular process, which is this area of bone here. We do that by making a cut here and a cut there. Remove that whole piece of bone. That whole piece of bone then gets ground up, and that gets used as local autograft to help augment the fusion. We then take off the remainder of the ascending articular process, which is the level coming above. Again, more bone graft for us. And at that point, we have access to the disc. And so then we're going to take out the disc here. This is the dural sac. This is a cadaver, so it looks a little bit purplish, but it's usually a lightish bluish color. And so here we do a discectomy and hollow out the disc completely, right through this corridor that we just created. The advantage of a T-lift over a PLIF, so posterior lateral or posterior lumbar interbody fusion, is typically done a little bit more medial, where you have to pull the nerves out of the way. The advantage of this approach, either open or MIS, is that the corridor to take out that disc doesn't require retraction of the nerves. It's right in the axilla, or right in a triangle, in between the nerve that exits out and the nerves that travel down. So you have a nice area there to which you can work and do the surgery. Then we put a cage that sits into the disc space. Within that cage is usually bone graft that we took out to get access to the spinal canal, as well as some bone from a donor or a cadaver. We also pack the disc space full of bone, and so we typically pack bone graft all around and put the cage in the middle. And then we get to work with our decompressive surgery. And that decompression involves taking the pressure off the nerves to the side that we're working on, as well as to the opposite side, again, in an over-the-top technique, so that we're not doing any decompressive work on the other side. And then we put in our pedicle screws, and we can do this straight down the tube. There's also percutaneous approaches to do that, and it's a little bit of dealer's choice. I like to put them down the tube just because it's easier. I'm already looking at the place where they go. We reorient our table. There's a lot of talk right now about getting lordosis, or getting the angle back in the lumbar spine the way you need to, and so we can do that with minimally invasive approaches just as well as we can do it with open approaches. Then we drop the tubes down to the other side, and the reason we're doing that is to put screws in the other side and to decorticate and fuse the joint on the other side. And personally, I think that's incredibly important, okay? In my patients, I see them fuse the joint on the other side first, before they fuse the joint on the side, or before they fuse the disc space where we do all the other work. And once you fuse the joint, you almost always go on to fuse the disc space. So just an example of some final x-rays. And again, skin incisions don't matter, but we all like a little bit of show and tell. And so that's typical for a minimally invasive fusion. So how about obesity, right? So in the United States, obesity is a huge problem. There are several providers in the area that believe that patients who are obese should not have spine surgery, period, particularly lumbar fusions. I would argue that the data is now out there showing that patients with morbid obesity can do really, really well with particular spine surgeries. And I think minimally invasive surgeries play a big role in that. But there's a couple things to keep in mind. Number one, surgery is harder. It's more complicated. You got to position a little bit differently. You need special tables so the belly can hang free. The trajectories are really, really important. And you're working at a longer distance away from the spine. So you make a small movement up top, it triangulates to a large movement at the bottom. And so there's some technique modifications that have to be made. Now, I mentioned percutaneous versus open screws. I think they're a horse apiece, particularly for one-level fusion. I find that using percutaneous screws is beneficial, where you pass in a wire and using an x-ray machine to put in pedicle screws. when you're doing fusions that are higher up and at more levels. But with one level surgery, I think it's just a matter of personal preference. So what does the data show? Well, these are the initial studies done looking at open versus minimally invasive surgery. And what we can tell you is that blood loss is less than minimally invasive. The operative times were equal, but hospital stay was significantly less. If we look at minimally invasive fusions versus open fusions, again, this is old data, okay? This is back 2005. These are the initial pioneers in doing these procedures. Jim Schwenner, Twin Cities Spine Center, this is who I trained with. Minimally invasive surgeries had much less blood loss. Operative time was longer, and hospital stay was significantly shorter, okay? But if you look up here, even in Jim Schwenner's study, hospital stay was still 2 days. Now, just going on Google, going to PubMed a couple days ago and getting ready for this study, there are now a zillion studies comparing open to minimally invasive fusion. These are just a couple that I found. And so, number one, outcomes are now being shown to be better. So with the minimally invasive fusion, ODI scores were better at both 1 and 2 years. Here's a study showing fewer systemic complications, shorter hospital stays, lower blood loss. Well, this part I think we've shown. That part we've definitely shown. Again, Goldstein, lower blood loss, shorter hospital stay, significant cost savings, right? We're starting to talk more and more about that in healthcare. If you're in the hospital for a shorter period of time, you have fewer post-surgical complications, you are lower cost. Fewer medical complications, with technical complications being equal between the two groups. Here's another study showing reduced surgical complications. Again, lower complication rate, shorter hospital stays, reduced blood loss. And so the data is now out there showing some of the things that we expected to see. So it raises the question, why doesn't everybody do it, right? If it's that much better, Dr. Strothman, then everybody should be doing this type of surgery. Well, it's hard, right? You got to learn how to do it. I was fortunate. I trained with somebody who was one of the pioneers in developing it. So I had that training and fellowship. Other people now coming into practice are going to have that training. So I think we're going to see a shift from traditional open surgeries to more and more minimally invasive surgeries as we get more and more people in the community that are trained to do these types of things. But it's a steep learning curve, and it's hard to force people to change. So a couple of case examples. This is a patient who presented with spinal stenosis. Really a character. He ended up moving to California, but just a character. When we looked at his images, he looks to be stable. This is one of my first minimally invasive decompressions. So we did a minimally invasive decompression on this patient at L4 or 5. There's his intraoperative x-rays. And we planned to admit him. So we admitted him to the hospital. We weren't really sure how these things were all going to pan out. And then in between cases, we went out to grab lunch, got a healthy meal at McDonald's at Abbott. And there was our patient sitting there having lunch. It wasn't 3 hours after his surgery. He snuck off the floor. He was in his gown, sitting at McDonald's, having a cheeseburger. And my PA and I looked at each other like, does he need to be here? Right? I mean, is there a reason for this guy to be in the hospital? And so the bottom line is no. And so now every one of our one-level minimally invasive decompressions goes home the same day. Almost every single one of our minimally invasive two-level decompressions goes home the same day. Every discectomy goes home the same day. These are no longer inpatient surgeries unless somebody has a medical comorbidity that requires them to stay in the hospital, okay? That is what the hospital is for now. It's for treating the medical comorbidities that go along with these surgeries because people do not need to be in the hospital following these surgeries. So this is just a disc herniation. And so again, here's a picture showing the disc herniation. I don't know if it projects very well, but the herniation is right over there. Here's another example of a synovial cyst. And so this big white structure right there, that's the cyst. That's pressing on the nerves. You can just imagine how painful that would be. Synovial cysts are an outpouching of fluid, right? They're not a tumor. They're not a cancer. They don't need to be biopsied. They're just an outpouching of fluid associated with degenerative arthritis within the joint, okay? That fluid then presses on the nerve very much like a synovial cyst might in the knee. It's just there's no space for it, right? So when it presses on the nerves, it's very painful. This is a really nice case for illustrating some of the advantages of minimally invasive surgery. And so this is a patient who presented, really nice gentleman with severe right leg pain, okay? Really no back pain, just horrible right leg pain. And what you notice on the x-ray, if you look here, see how these two bones are tilted towards each other. You see a little triangle of a disc space instead of the normal flat disc space you see there. So he's got a localized asymmetric disc collapse or degenerative scoliosis. Well, the effect of that is as the bone collapses to the side, it narrows the hole where the nerve exits out. So if you look at this model here, the nerve comes out a hole. It's bounded on the front by the bone and the disc, and the back by the joints. Well, as the spine tilts, this bone falls on that bone, which then sandwiches the nerves in between it. So if you look at this MRI scan, here again, bone, bone, there's the pedicle in the back. Here's the nerve. See how it's got this white space around it? You can even see it better there. Nerve, white space around it. That's the normal neural foramen. That's what the nerve should look like when it exits out. It doesn't look right there. You can't find the nerve. You can't find any white space because the way that spine has collapsed upon itself. Well, the only way to open up that hole and keep it open is to actually correct the patient's alignment. You got to pull the bones back apart from each other, hold them apart, clean out the space around that nerve. So that's what we did. We did it minimally invasively. You can see the intraoperative x-ray here. Here's this post-surgical x-ray, right? So again, if you look at this space, you can see how it's tilted on top of each other right here. This is where that nerve was pinched. Now those bones perfectly flat, held in place with titanium screws and rods. So this is a video, which I don't think it's going to work. I'm going to try to click on it. Oh, it does work. So this is this gentleman literally 2 weeks after surgery. You would never know that he had an operation. He came in before surgery and couldn't walk. Just incapacitated with pain before surgery. And at 2 weeks, no pain. So isthmic spondylolisthesis. So I don't want to get too much into this, but there's there's 5 different types of spondylolisthesis. We've been talking about degenerative, but with isthmic spondylolisthesis, what we have is people have fractures in the back of the bone. It's actually present in 4 out of every 1,000 kindergartners. Okay, so they're very common in the population. But what ends up happening is the disc itself wears in time, and because you have those fractures in the back of the spine, it disconnects the back of the spine from the front of the spine. The bone starts to slip forward because the joints are not connected as the disc wears. As that bone slips forward and collapses downward, it pinches the nerves as they exit out. So this is a gentleman came in with 80% low back pain. So again, this gets back to our conversation, back pain versus leg pain. He comes in with 80% low back pain, a long history of pain, been really severe for the last 5 months. He can only walk 1 or 2 blocks. He can stand for only 5 minutes, right? Imagine being only to stand for 5 minutes. It makes it really hard to do anything. But he could sit forever. No pain at all with sitting. So again, this is a patient who's presenting really with symptoms of nerve root impingement, okay? He had an injection, which we'll use oftentimes to try to clarify how much of somebody's pain is nerve pain versus how much of their pain comes from arthritis or other factors. He got 80% relief at 3 hours, but then no long-term benefit. So the numbing medication we put in knocked his pain away completely, but the steroid wasn't strong enough. It couldn't work because his nerve was still pinched. He still got the same problem. So here's his images, and what we're going to see is this disc here is wearing out a little bit, starting to bulge a little bit. This disc down here, though, is more and more. You can see that it bulges there. And if you look real close, you can see the back corner here and the back corner there. They don't quite line up right. Now, the middle of the spinal canal, wide open. Okay, this throws people for a loop sometimes. Because in isthmic spondylolisthesis, in this type of slip, the back of the spine isn't connected to the front. So as the front slips forward, those concentric circles we were talking about, they're not moving anymore because the back's disconnected. So it actually makes the spinal canal bigger. But the hole where the nerve exits out is the problem. So you look there. That's the left neural foramen. There's no space for that nerve. That's the right side. See all the white right there? So tons of space for the nerve on the right. That's why he's not having right leg pain. No space on the left. So this is the problem. It's the nerve that's pinched that's the problem, but the way that you have to treat it is with the decompression and infusion. And so these are his x-rays. Now you can see that slip here is just a little bit more prominent. And then again, x-rays showing that when he bends forward, this bone is slipping further forward than what it was before. So he's got left L5S1 foraminal stenosis. He's got an isthmic spondylolisthesis. He also has some disc degeneration at L4-5. That would cause a lot of people to think, well, gosh, he's got 80% back pain. We need to fuse both levels. You don't. So we did a minimally invasive decompression of 4-5, so you also had a little bit of some pinched nerves there. And then we did a minimally invasive fusion and decompression at L5S1. He did great. I don't have the data here, but literally nearly pain-free by 3 months after surgery. And so this is a little bit of a show and tell case right here. You can do 2 levels minimally invasive. This is a gentleman who had a 2-level minimally invasive fusion at 4-5 and 5-1. The illustrative points here, this is a skin incision from a discectomy that he had in his past. This is the skin incisions from his two-level fusion. They're roughly the same size as the way we used to do a discectomy. Now again, skin incisions don't matter, right? The point there is that we're just referencing the amount of damage that we used to cause during a simple discectomy compared to what we're able to do today with a fusion operation. So there are good candidates and some that aren't such great candidates for minimally invasive decompressions. The more soft tissue you have, the better a candidate you are for minimally invasive decompression. The more bony narrowing you have, you see how much bone is down here, the harder that decompression is going to be. And then as the joints become straightforward, as you see here, the potential to induce instability becomes higher. You can see these joints are more angulated than these joints, which are quite straightforward. So I want to take just a couple minutes, tell you a little bit about what we do. So I was part of Institute for Low Back and Neck Care. We merged with Summit Orthopedics in January, so now we are part of Summit Orthopedics. We have, again, taken surgical care a step further and are doing everything we can to transition surgery to the outpatient environment. And so we have a center in Vanders Heights right now. We have another center that we're building in Eagan that combines state-of-the-art surgical suites with overnight care suites. This is completely changing the way that we think of all orthopedic surgery. Okay? We've done 123 advanced spine cases since 2014. This includes anterior cervical decompressions and fusions, total disc arthroplasties, and lumbar fusions. Okay? We are doing lumbar fusion surgeries as an outpatient. Okay? Now, this doesn't mean that we're doing it in a small center without the same equipment and we're forcing people out the door that are miserable and ended up in the ER. That's not the way that this is done. And so instead, we have the same equipment that we have in the hospitals. We even have intraoperative navigation or O-arm and stealth navigation if need be for providers that want it. We have every single resource that we would want from the hospital, but we also are able to use some medications that the hospital deems to be too expensive, so patients have less post-surgical pain. We have nurses that are dedicated to doing one thing and one thing only, and that is keeping the patient happy. There are our nurses, and they care deeply that every patient has the best possible experience. You can't get that in a hospital where the people that are providing the care aren't employed by you. On top of that, everything's simple. It's small. It's easy. You're not parking and walking 7 miles trying to get someplace. So patients absolutely love it. On top of that, we're doing these surgeries at a significant cost savings at 30 to 40% of the cost of inpatient surgery. Imagine that, saving 40% on the surgery simply because you had the operation done somewhere else, right? Now, we also have the ability to keep patients in our center for as long as we want. And so we have care suites that are beautiful, that are built in, that if you're having too much pain, we can provide pain management, and you can stay with us for a day, 2 days, 3 days, a week. Nobody does. Almost everybody goes home the next day before noon because they're doing that well. A couple little slides to show you again minimally invasive versus open. This is our data. This is the way we do things. And so if you look at Sport trial that I was showing you earlier, they had an average blood loss for an open laminectomy of 300 cc's. Their operative time was 120 minutes. Their length of stay was 3 days in the hospital from a one-level open laminectomy. Well, our blood loss with a one-level decompression is 5 cc's, and that's rounding up. It's really next to zero, but you got to put something. So it's always 5 cc's, okay? The operative time is 60 minutes, and that includes putting the patient to sleep and waking them back up again and closing their skin and getting out of the room. The actual surgical time is about 20 minutes. It's just a vastly different surgery than it used to be because you don't have to strip all this stuff out to the side to see this one area. All you need to do is get to there. Length of stay, they're now all outpatient surgeries. Everybody's an outpatient. So 3 days to literally 0 days. Open fusions versus minimally invasive fusions. Again, if we compare to Sport, this is the data from Sport showing that 500 to 950 cc's of blood loss was the average for an open fusion. Operative times are 150 minutes to 240 minutes. Length of stay range between 5.5 and 10 days, okay, for a one-level open fusion. Well, at our center, our average blood loss is 75 cc's, again, showing that dramatic difference in blood loss. Our operative time for one-level fusion is 120 minutes door to door. Okay? The whole operation usually takes less than 90 minutes. Length of stay is usually less than 24 hours. So huge paradigm shifts in how we think about things and how we do it. At the end of the day, this is all about providing the best patient experience, providing the best outcome you can at a lower cost. I really like this last slide because we all talk about excellence, and the real trick is continuing to pursue it as aggressively as you can to provide for the patient as best that we can. It's not about what we can do for ourselves. It's about what we can do for the patients to improve their outcomes and improve their costs and their experience. Any questions? Yes. I think they want you to use a microphone. Maybe right there. I think he's going to grab it for you. There's people online or something that they want to be able to hear your... Thank you.
Can the screws, the hardware, be removed in the future after this, after it's stabilized, or do the screws and all the hardware have to stay in?
Yeah, so great question, and the answer is yes. They can come out. The one downside that I've seen with minimally invasive fusion surgeries is that because the muscle is still alive, it still contracts and moves over the top of the screws. So I end up taking out more screws at a year after surgery with minimally invasive fusion as compared to open fusions. Because in the open surgery, that muscle is still dead. It doesn't hurt because the muscle is not moving. In minimally invasive surgery, that muscle is still alive, and so they can be irritating, particularly to young active people. So we are a little bit more likely to have to take the screws out at a year.
What's the negative to that? Is it less stable than after you do that?
No, the screws are an internal brace, so
Okay.
their function is to hold things stable so the bones heal. Once the bones have healed, you no longer need the screws. The screws are purely extra at that point, and so they can be removed very safely. Yes?
I've been working with patients who have, similar symptoms to what you're describing, where there might be the actual MRI might be a little bit ambiguous, but they've got the radicular symptoms. And what I'm seeing is that they have a negative EMG. A lot of IME physicians and even like neurosurgeons are saying, well, they're not a candidate at all for surgery. I know that you and others do these injections. You're talking about the nerve root injections. So one part of my question is, what about these EMGs that are supposed to be the magical, cutoff point? And then the second part is with these injections, your case was 80% relief. What about the people who have 40% relief, 50% relief, 30% relief? I mean, that also seems to be like some cutoff point, and a lot of decisions are made on that.
So great questions, and I love the shirt, by the way. So the first question is EMGs. EMGs are a difficult study, okay? We don't have anything in medicine that's absolute, but yet there are providers that look at an EMG as an absolute test. If the EMG is negative, then they don't have a problem. And I look at EMGs totally different. They're not quite useless, but they're very, very close to useless, okay? I have seen patients with a horrible radiculopathy with a completely normal EMG, and I've seen patients who have an EMG that shows that they have an L5 radiculopathy, and the L5 or L5 looks totally normal. There's no pressure on their L5 nerve root at all. And so I've seen it so many times both ways that the only use in my practice for an EMG is in something where you're really puzzled. You're just trying to get another piece of information to try to understand it. But it doesn't really rule in anything. It doesn't really rule out anything. So just not as useful. And I think what we're seeing in IMEs is people just trying to have a data point that they can use as an argument against somebody for getting care, which unfortunately is a little bit the way the situation or the system has developed, right? You have a doctor on one side and a doctor on the other. But the EMG itself is really not all that helpful. Nerve root injections are really two parts to that question. The first is, what do you do with patients who seem to have a radiculopathy, but the MRI scan's a little bit equivocal? And the answer to that is complicated, but you got to think about what your tools are, right? If your tools do an open laminectomy with a larger blood loss, with a lot of collateral damage, to try to decompress a nerve that's mildly pinched, that's a big intervention for an uncertain outcome. If your tool is a minimally invasive surgery that has almost no blood loss, that you go home the same day, that's very low risk, you're more likely and more willing to decompress a nerve that may not be as badly pinched, but certainly seems to be causing symptoms. Because your risk isn't as high as what it would otherwise be. Your downside isn't as high as what it otherwise would be. And so I do think that minimally invasive approaches allow us to be a little bit more aggressive with that patient who has a radiculopathy, and you're looking at the MRI scan and you're like, ah, gosh, it looks pinched, but gosh, your symptoms are a lot worse than what I would expect it to be for this. And that dovetails into this nerve root conversation because we use nerve root injections to try to help us make that decision. And so there's some data out there showing that the diagnostic response from a nerve root injection, when that nerve is numb, right, and only that nerve is numb, it can't feel pain. So if we numb a nerve and all the pain goes away, it means the pain came from that nerve. It didn't come from the joint, it doesn't come from the disc, it doesn't come from somewhere else, it comes from that nerve. So we use those injections to help determine if a surgery is going to be beneficial. Because if people get better than a 70% diagnostic response on a nerve root injection, the corollary is they will very, very likely do well with surgery to get the pressure off that nerve, whatever that surgery ends up needing to be. But if they get less than 70% diagnostic relief from the injection, there is some placebo response of people just wanting to get better. And so then they fall into this really nebulous area. Is it going to help? Is it not going to help? And this gets into a little bit of that art where we don't have hard science to follow us up. And so you got to rely on what you know about the patient, their exam, the MRI findings, and you have to have a conversation with the patient because at the end of the day, right, they're the consumer. It's their life, right? So we educate the patient and say, hey, you know what, you only got 60% relief from this injection. The nerve appears to be pinched. Your symptoms correlate with an L5 nerve root pattern. It certainly seems like this is the problem, but you only got 60% benefit from this injection. We're not certain if we take the pressure off that nerve, if you're going to get all the way to where you want to go. And so do you think that the relief you got is worth it? Do you think that if you felt the way that you did following that injection, but it didn't wear off, is that enough? And we'll phrase it that way to people and sit down with them. And sometimes we'll repeat the injections with just numbing medicine and sit down and talk about it again. But as you get less than 70% benefit from a selective block or a nerve root injection, surgery becomes increasingly less predictable.